Danielle, please go ahead and talk about the SYNGAP1 from the, in this case, Canadian perspective. Yeah?
Well, the advantage of these little technical issues is that it gives people time to ask questions, so it makes my life a little easier. So I'll probably go fast here with some of these slides. You already know about this, and you already know that Syngap is not an epilepsy, not just a disease with intellectual disability, but it's a really whole systems problem. So most of what we know about Syngap is in children, and this is natural. The gene was identified recently, and so the older adults, when they were young, they had the $1 million workup, but there was no gene. The gene was not known at the time, so they didn't have a diagnosis, and they went on with their lives looking for treatment, but without really a diagnosis. So we are now identifying these older adults, but so far the literature in adults with SYNGAP1 is very small. About 2 years ago, we published our first evaluation of 14 adults with DEE. So these were patients with Syngap and severe epilepsy, the definition that you just heard beautifully by Dr. Ingrid Scheffer. And so what you're going to hear in these next 2 slides are about adults with Syngap and DEE. Median age was 21, ranging from 18 to 65 years. 71% of them still had drug-resistant seizures treated with a median of 2 anti-seizure medications, and no adults were able to read or understand verbal material at the 6th grade level or higher. Only half of the adults could walk with minimal or no assistance. About 86% of them had sleep disturbance, social communication disorders, and aggressiveness, self-injurious behavior. And in fact, it was the aggressiveness and self-injurious behavior which caused the most distress and increased caregiving burden. 71% had constipation, and the only genotype-phenotype relationship we could see with that small group was one patient with a partial exon 3 deletion that had greater daily living skills and social skills compared to the others. So after that, we were lucky enough to receive a grant from SRF to study more patients with Syngap, more adults with Syngap, and we decided to study both adults with and without epilepsy, or with and without DEE. So we had initially aimed to study 30 adults, and this is a 2-phase study. First one is chart review, caregiver-reported outcomes, and the second will be a genotype-phenotype correlation. So what I'm going to show you here is a partial evaluation. So we did not complete phase 1 yet, but we have data in a number of patients, and that's what I'm going to be presenting. So we recruited patients from different places. We had the Canadian site recruited most of the patients from Canada, US, certain places in South America and Europe. We had one site in Brazil and one site in the Netherlands that did their own recruitment. And here are the things we are evaluating: seizure severity and treatment, behavior and adaptive skills, sleep, communication, quality of life, GI, and pain. And here are the tests that we are using to evaluate those things. So after a while to get all the research ethics, board approvals, and everything, we were able to identify 134 adults. We initially recruited 99. We got consent in 71, and we have 57 that completed most part of the phase 1 study, and 4 that were we could not follow up. We didn't follow up or they were not able to continue the study. So what I'm going to be reporting is the results we have on those 57 patients. So their median age is 22, about same male and female. Here's the genetic variants spread throughout the entire gene, but more clustered in the initial part. We do have 10 splice site variants. Someone was asking about that recently. In terms of epilepsy, 68% of the adults still have epilepsy. And when you asked about the frequency in the last 12 months, non-convulsive seizures were seen in 20% once a month, monthly or more, 20% or 19% at least once in the previous 12 months, 14% monthly, 11% weekly, and 19% daily. And with the convulsive seizures, we had 4% having daily convulsive seizures, 4% having weekly convulsive seizures, 11% monthly convulsive seizures. When you look at the types of seizures, atypical absence and myoclonic are the most common ones. And then we have the other ones. I'll just show you this next slide, which is the previous seizure frequency prior to 5 years of this data point collection. So what you see here is that in the past, the patients tended to have more of all types of seizures. So atypical absence was 46, came down to 42, not too much. Myoclonic from 33 to 32, not too much. But look at status epilepticus, the line in yellow. It was 18%. Infantile spasms, 18%. And in adults, 2% and 0. So those seizures decreased significantly. Reflex seizures from 28 to 14. So you do see a decrease in some types of seizures. Atypical absence and myoclonic seems to be the ones that persist in adults. In terms of the number of seizures, they have a fewer number of seizures now than in the past. And when we asked about intellectual disability, the majority of patients have moderate to severe and some with profound. So about 4% had mild ID, and in 4% it was not possible to tell. Regarding screening for autism, social responsiveness scale, so moderate and severe captured about 40 of the patients, mild in a smaller number, and within normal in a very small number. We also we asked about walking abilities, and for that we used the functional mobility scale. That's a scale where you ask patients, or you ask the parents, how far can patients walk with assistance or without assistance. So if you look here, the lower bar is the best. As you go up, is worse walking ability. So the lower one, the patient can walk, run, climb stairs in any uneven terrain without any difficulties. And as you go up, they will need assistance for uneven terrains, then they will walk outside for communities distance, but only on surface level, or they can only walk indoors, or they cannot take any step at all. So if you kind of collapse this and you say, patient really can't walk outside the house, like little steps to go from the bed to the kitchen table. So those are patients that really can't walk. Patients that can walk with assistance and those that can walk independently. We see that the majority at this point can walk with assistance, almost 50%. 40% can walk independently, and we have 14% that really can't walk. We have to look further at this to see if the age is playing a role here. I suspect it does. But these are, like I said, preliminary numbers. Now, this is something interesting. When you look at the functional mobility scale and the epilepsy status, you see no difference, meaning it doesn't really matter if the patient has epilepsy or not. They have, like, we don't see a statistical correlation between having epilepsy and having difficulty to walk. But when you ask the parents their impressions, so what is the patient's ability to walk, they have, and this is a different way of asking the question, so it's more like a Likert scale, so the caregiver reports like in a not very much or middle or a lot. They feel that patients that have epilepsy have a much worse walking ability than what we detected on the functional mobility scale. So interesting, not sure why. We can speculate maybe the patient can walk, but caregiver might be a bit afraid that they can have a seizure and fall and injured. So they see the patient a bit more limited than what we detect in other scales. We'll have to explore that. Similarly, caregivers have an impression that patients that have epilepsy have more problems washing and dressing themselves than those that don't have epilepsy. In terms of sleep, about 44% can sleep between 8 and 9 hours, another 23% between 9 and 11, and the rest will sleep less. But even those that sleep a good number of hours have significant challenges. So we saw that excessive somnolence in about 60%, and disorders initiating and maintaining sleep, the last one, are very, very common. But they also had problems with breathing disorders, sleep breathing disorders, disorders of arousal, waking up, sleep transitions, and hyperhidrosis. And as expected, convulsive seizures were correlated with increased difficulties breathing when sleeping, seizures correlated with increased difficulty during sleep and gasping, associated with excessive sleep disorder, and excessive sleep correlated with lifetime status and lifetime use of anti-seizure medications. In terms of GI outcomes, about half of the patients use some medication for constipation. Diarrhea doesn't seem to be a problem, might be mild in 35%, and there's a few patients that have more severe diarrhea. And regurgitation is also not a severe problem, although a large proportion of patients do report on some mild regurgitation. In terms of caregiver quality of life, we asked about fulfillment, relational problems, mental health, daily activities, financial problems, support with tasks, and caregivers' physical health. And the main correlation that we saw is that patients with seizures, the caregiver mental health is associated with convulsive seizures. So that is a huge issue regarding caregivers' overall quality of life. Regarding patients' quality of life, and again, this is by proxy. These are caregivers reporting how they feel their loved one quality of life is. They reported challenges in mobility, self-care, usual activities, pain not so much, and anxiety not so much either. So we asked about pain. So it has been reported that patients with SYNGAP have lower tolerance to pain. We have seen that in our previous study in adults only. And we asked again, and we asked the question so again, asking the parents, if you see that your child has a higher tolerance to pain compared to yourself, compared to kids of the same age or adults of the same age, and related to the pain stimuli. So if it is a tubbed stool, they don't have too much pain, but if it is a broken bone, what is the level? And overall, across the board, they say that their pain is lower than expected compared to peers, comparing to caregivers, or compared to the level of painful stimuli. So this is the initial results that we have. We're trying to understand patients with SYNGAP in a more holistic way, understanding how they grow up, and the next step will be to do genome phenotype-genotype correlation. We do have DNA in 53 patients so far, so we're still collecting DNA, and we hope to finish this by hopefully next year. So I will stop here, and I want to thank all of our collaborators. SRF, amazing. We couldn't recruit patients without you. Have done like an amazing job. We exceeded our goals of recruitment by several folds, and all our collaborators, Dr. Katy Valenti that is here, and many others that are not here. Thank you.
Thank you, Danielle.